Good morning, respected jury and my colleagues actually. Today I am Dr. Divyam Suri from Kastuba Medical College, Manipal. I will be discussing regarding case series on a hidden spectrum of euglycemic decay, case series highlighting diagnostic pitfalls and common clinical presentations. So, by introduction, we already know that euglycemic decay is a rare but serious complication of diabetes characterized by high anion gap metabolic acidosis and ketosis in the absence of significant hyperglycemia. It has gained increasing attention with the widespread use of SGLT2 inhibitors, but its occurrence is not confined to pharmacological triggers alone. Even conditions such as pregnancy, infection, starvation, and alcohol abuse can also precipitate euglycemic decay. So here we present case series of 4 patients who have confirmed euglycemic decay who initially presented with misleading symptoms resulting in diagnostic delays. So via these case series we aim to raise clinical awareness and emphasize the importance of early recognition to ensure timely and effective management in these cases. So my materials and methods including these 4 cases. First case was euglycemic decay diagnosed in pregnancy, where a clinical presentation was a female 28-year female primary gameta came at 10 weeks of gestation, which presented with persistent nausea and vomiting for 3 days, associated lightheadedness and reduced oral intake. On examination, she had tachycardia, was mildly dehydrated, and pallor was noted. Initial was diagnosed as hyperemesis gravidarum as she presented in first trimester but required further evaluation and was advised admission but was not willing for that. Hence, initial labs were sent, however she didn't follow up for that afterwards. Initial lab findings were showing PCV of 37% which showed hemoconcentration. Sodium was normal, potassium was normal, and even blood sugars were normal, which was 90, and beta HCG was 1,20,000, which confirmed pregnancy. However, urine ketones at that time was only 1 plus. Later, she came in a worse state with us to the emergency actually, which she had persistent vomiting and tachypnea. At that time, repeat ABG showed high non-gap metabolic acidosis with pH of 7.25, bicarb of 14, and a 9 gap of 20. Hence, serum ketones were sent, which came positive for beta hydroxybutyrate up to 6.2, urine ketones, and still she had sugars of 100 only. So she was diagnosed with euglycemic decay, which came in pregnancy unmasking overt diabetes, because at later date her HbA1c which was done, which was also high, which was 7%. Management wise, she was initiated on DNS with fluids and insulin infusion side by side. Electrolytes and ketones were monitored, and once she ABG normalized as well as a 9 gap closed, insulin infusion was transitioned to subcutaneous insulin, and later on she was on the discharge was planned to continue in, sugar monitoring and was discharged on basal bolus regimen. Fetal viability was confirmed by ultrasound for her, which was normal at that time. So, key take home message via this case is that pregnancy can mask previously undiagnosed diabetes, which may present at the first presentation as a euglycemic decay. So, symptoms like persistent vomiting in presence of a high anion gap metabolic acidosis should be considered for euglycemic decay and should be treated promptly. Second cases which we commonly see case scenarios due to SGLT2 inhibitor induced euglycemic decay. In this case, a 58-year-old male who is known diabetic, CKD and heart failure with reduced ejection fraction came with nausea, vomiting and fatigue. On examination, he was dehydrated, tachycardic and had a foul-smelling ulcer over his plantar aspect. Key medications which he was already on, he included dapagliflozin, glimepiride, vildagliptin and electron. So initially when he came, he had anemia with high race counts as well as high HbA1c of 8.4% with the race CRP suggestive of infection, as well as urine were positive for ketones. Labs were done which showed ABG which showed metabolic acidosis of pH of 7.23, bicarb low of 17 and high anion gap of 18, which was suspicious of euglycemic decay, hence serum ketones were sent, which also came positive. But however, the blood glucose were in the normal range only, about 131, indicating euglycemic decay. So he was diagnosed with euglycemic decay precipitated by infected diabetic foot ulcer likely due to SGLT2 inhibitor use. So management was initially due to dapagliflozin was withheld temporarily, was started on broad spectrum antibiotics as per the culture sensitivity report, and insulin infusion and DNS was started. Once he recovered, insulin infusion was tapered and was transitioned to subcutaneously. Key message from this presentation is, in patients of SGLT2 inhibitors, we should keep an eye on glycemic decay, which can occur even with normal blood sugar levels when precipitating factors like infection are present. Third case is from alcoholic to euglycemic decay. In this, an patient, 30-year-old male with a 10 history of alcohol use, alcohol dependence syndrome, and a history of recurrent pancreatitis in the past for around 2 years. He was repeatedly getting admitted for recurrent pancreatitis in outside hospital. This time also he came with complaints of 3 days of epigastric pain and vomiting, followed by which was followed initially by binge drinking episode of about 5 days. So initial treatment, he was treated at peripheral hospital where ABG was done, which showed metabolic acidosis, pH of 7.28, bicarb of 16 and 9 gap of 14, and was treated outside as an alcoholic ketoacidosis with dextrose and thymine. However, he didn't improve with this and came to us in a state of persistent symptoms with worsening tachypnea and was referred here. On referral here, he had worsening acidosis suggestive of ABG of pH of 7.22, bicarb of 13 and a 9 gap of 18. Hence, in view of suspicion of diabetic ketoacidosis, serum ketones were sent, which came high, as well as on presentation his HbA1c was 9.1, with low insulin and C-peptide levels, suggesting of endocrine insufficiency in him. Later, a CT abdomen was done after stabilization, which also showed dilated ducts with calcification, suggestive of acute and chronic pancreatitis, and his diagnosis was revised to euglycemic decay secondary to pancreatitis-induced diabetes in him, that is type 3C. He was managed as regularly with fluids, insulin infusion, potassium replacement, and also on the day of, near to discharge, he was started on pancreatic enzyme supplementation following stabilization. So, key take-home message by this is that we should consider euglycemic decay in alcoholic pancreatitis because they can develop type 3C diabetes also due to insulin deficiency. Last case is of euglycemic decay due to metabolic encephalopathy, where a patient came with altered sensorium, was on metformin and basal insulin at home. He was febrile and confused. However, there was no history of any missing insulin dose. Initial labs also showed elevated lactate with metabolic acidosis. Hence, was provisionally managed as urosepsis with septic encephalopathy and lactic acidosis. However, urine ketones were only 1+ and sugars were normal at the presentation, which was 135. However, even starting on broad-spectrum antibiotics like peptides, he didn't improve. So his sensorium was worsened, hence repeat ABG was done, which showed high 9 gap metabolic acidosis, suggestive of euglycemic decay, and serum ketones were also positive for beta hydroxybutyrate. Hence diagnosis was revised to as euglycemic decay with septic biometabolic encephalopathy. Same management was done, was started on insulin and IV dextrosaline with electrolyte monitoring. Key messages in this is, in elderly diabetic patients, we should consider euglycemic decay when there is persistent metabolic acidosis in presence of an coexisting infection, even in the absence of SGLT2 inhibitors or missed insulin doses. So discussion wise is already we know that SGLT2 associated euglycemic decay is there. All 4 cases have shown that. Conclusion wise, these case series we highlight various clinical triggers and presentation of euglycemic decay, and clinicians should consider these and maintain a high eye of vigilance in these cases actually. Early recognition and timely management are essential to prevent morbidity and improve outcomes in these patients. Thank you.
First case that you mentioned, the lady with decay, euglycemic decay.
Yes.
So, do you think there could be a possibility of type 1 diabetes presenting like that, and did you look for that in that patient?
Yeah, ma'am, we actually...
And did you follow up that case?
Yeah, ma'am, we actually did investigations during that time only. C-peptide and insulin levels were done, which are actually normal only, ma'am.
C-peptide was normal?
Normal only.
The third case is an elderly person with sepsis. So the sepsis itself can contribute to glycemic fluctuations.
Yes, ma'am.
So what is your inference from all this? SGLT2 inhibitor in the second case, you said the patient was starving also.
Yes, ma'am.
So what is a common cause for SGLT2 inhibitor induced euglycemic ketoacidosis? Is it a poor calorie intake or infection, or commonly seen in clinical practice?
SGLT2 inhibitors causes glycosuria, ma'am. So due to that, even on presentation, normal glucose levels will be seen. Plus that already if the patient is on SGLT2 inhibitors, he should have any precipitating factors like he's even not taking properly food, he has starvation, or he has an ongoing infection in him, which was there present in my patient, like he had an infected foot ulcer. That infection has actually precipitated euglycemic decay on the background of an SGLT2 inhibitor use.
As a physician, what would you advise a patient of yours whom you start on SGLT2 inhibitor? You have already presented a case like this.
Yes,
So
ma'am.
do you give a black box warning to the patient? Say, you're on this drug, you should stop it. When should you stop it?
Ma'am,
If there is poor food intake due to illness, would you advise the patient pre-operatively before any surgical intervention? So what is the takeaway from each case of yours?
ma'am, takeaway from my each case is that clinicians should maintain an vigilant eye towards euglycemic decay, not only just rely on normal glucose levels, because ABG is a key tool in identifying diabetic ketoacidosis, but some clinicians rely only on blood glucose levels and start treatment karke. So if treatment is started early in these cases, it can lead to good outcomes in these patients actually.
Question. How will you define euglycemic decay?
So presence of an high anion gap metabolic acidosis with normal glucose levels.
No. Is it diagnosed in patient with diabetes or without diabetes?
With diabetes, sir.
So in your first patient,
Yes, sir. Pregnant.
how do you diagnose diabetes?
In
Based
pregnant,
on HbA1c.
based on HbA1c cutoffs.
HbA1c could be always true in all the patients.
No, sir. Fallacies are there that
So
if
how will
patient
you
has,
confirm this patient has really diabetes or not?
via all, if all the criteria are
You
met,
told
sir,
C-peptide, GAT,
like
everything you
random
done
blood
is
glucose
negative.
levels, postprandial blood sugars level, and HbA1c, all three levels.
Why? Because pregnancy itself causes ketoacidosis and it's euglycemic. You all know that.
Yes,
And
sir.
only with HbA1c you are labeling someone as diabetes. It will be a tricky
Yes, sir.
scenario in this particular setting. One thing you can do is once hyperemesis sets in or it's went away, you can do a CGM. CGM could give you a estimated HbA1c in that. When whatever the stress that triggered the starvation and things sets in, then you can assess.
Yes, sir.
So it still may not be a euglycemic decay, although you include an euglycemic decay. Until you exclude that, we cannot call it as euglycemic decay.
Yes.